So good afternoon, everyone, and welcome all of you to this, the third of our series of virtual town halls on cybersecurity and digital privacy in the time of COVID-19. We are very pleased that you have joined us for what we hope will be a thought-provoking and compelling 90 minutes of discussion and debate on cybersecurity in Canada's health sector. A critical discussion to be having right now, and we're grateful that you've joined us, and we're grateful to this fantastic panel that's with us today and who I will introduce in just a couple of minutes. A few words of introduction. My name is Charles Finley, and I am the Executive Director of the Rogers Cybersecure Catalyst at Ryerson University. The Catalyst is a center for excellence in cybersecurity activities at Ryerson. Based in Brampton, Ontario, we deliver programs in training, commercial acceleration, support for applied research and development, public education and policy, all in cybersecurity. We deliver an accelerated cybersecurity training program to new Canadians, women, and displaced workers who demonstrate high aptitude in cybersecurity, and I want to welcome many of the learners from that program to this town hall. The Catalyst is proud to host today's town hall in collaboration with our colleagues at the Ryerson Leadership. The lab is Ryerson University's action-oriented think tank. Through leadership development, civic convening, and policy and research activation, the lab develops leaders and solutions to make progress on our most pressing civic challenges. The lab is also doing a great deal of superb work related to policy and COVID-19, and at the end of our session, I'll direct you to a website where you can engage with the lab in that work. Today's town hall is supported through the generous contributions of RBC, which is a major founding partner in Rogers Cybersecure Catalyst. This town hall series is a part of a new policy program that the Rogers Catalyst and Leadership Lab have launched with RBC, which is dedicated to advancing effective and innovative public policy in cybersecurity and digital privacy, and it is called the Cybersecure Policy Exchange. I would encourage you to visit our website, and I'll give you the URL for that at the end of the session as well, and get involved. It's going to be a very exciting and we hope productive effort. And I want to welcome many members of the RBC team to this town hall. Now, let us begin. As of course we all recognize, right now in the time of COVID-19, our healthcare system is being stretched as far as it can go, and in some cases beyond reasonable thresholds. Our country's doctors, nurses, home care workers, paramedics, hospital administrators, researchers, medical equipment manufacturers, and others are showing heroism in saving lives every day. They are saving lives while often risking their own lives in the process. Moving scenes of care and compassion are unfolding in hospitals, community centers, and nursing homes across the country. But while these brave people and institutions are saving lives, a large number of dedicated criminals working around the world are doing their best to threaten this work. Generally speaking, and not taking it out of the healthcare context for a moment, cybersecurity attacks, as we know, have surged in the time of COVID-19. Some sources are measuring a growth in phishing threats at upwards of 10x. Fake websites, and this is just to mention one of the threats we've seen, fake websites have been set up mimicking the sites of major international health authorities to draw in and defraud users. Within this overall surge, there have been specific and sustained attacks on healthcare organizations. And obviously these attacks are used to exploit healthcare organizations at a time of increased vulnerability. They are attempts to exploit in a real way the importance of the work that these organizations are doing. On March 20th, the Canadian Centre for Cybersecurity issued a special alert on threats to Canadian healthcare organizations. These challenges for healthcare organizations are, of course, acute right now in the context of COVID-19, but these are threats that we may expect to continue to develop after this particular crisis is over. Our healthcare system is changing quickly and fundamentally, becoming more dependent on internet-connected technologies, data collection, artificial intelligence, virtual delivery, and others. It is important for us to discuss the cybersecurity challenges for the healthcare system, not just now, but going forward into the future. So we are very fortunate to have with us a fantastic panel of leaders to share their thoughts on these issues over the next hour or so and to take your questions as well. I will introduce each of them to you and would ask each of them just to wave at the camera to identify themselves. Michele Mullen is the Director General of Partnerships and Risk Mitigation at the Canadian Centre for Cybersecurity, which is, of course, as many of you know, the lead public-facing federal agency on cybersecurity. The Partnerships and Risk Mitigation Directorate that Michele leads is responsible for providing security advice, guidance, and services to Canadian critical infrastructure organizations and for advancing collaborative relationships with private industry to strengthen cybersecurity practices in Canada. Michele is a highly experienced security and technology official who has held senior posts with the Communication Security Establishment, among other key agencies. The Canadian Centre for Cybersecurity has been doing tireless work throughout the COVID-19 pandemic and before it, and we're very grateful for Michele to take time out of her schedule to be here to talk about the threats that are facing this country and the healthcare system in particular, and Michele will speak in a couple of minutes on those points. Michele is joining us on the phone, so you don't see her in the screen, but she is on the phone. Dr. Jeff Curtis is the Chief Privacy Officer for Sunnybrook Health Sciences Centre, one of Canada's preeminent acute care research and teaching hospitals located in Toronto. In his role, Jeff is responsible for information privacy assurance, freedom of information compliance, IT governance and risk management, and corporate strategic planning activities. Jeff has held numerous senior advisory roles with government and large institutions at the intersection of healthcare and technology over the course of his career. Welcome, Jeff.
Thank you.
Mary Jane Dykeman is a partner and co-founder at Inc. Data Law. Mary Jane practices as a data lawyer and has decades of experience in the health sector and beyond. Her practice focuses on privacy, artificial intelligence, AI, cyber preparedness and response, and data governance. Mary Jane has acted as in-house counsel to 2 Toronto teaching hospitals and was instrumental in the development of Ontario's health privacy legislation. Mary Jane regularly works with CIOs, CEOs, and boards on the emerging risks and trends in data. Welcome, Mary Jane.
Thank you.
Last but not least, from California, Russell Rice brings over 20 years of experience in the network security industry and is current Vice President Product Strategy at Ordr, a Santa Clara-based company that has been getting lots of recent popular attention. Among many product offerings, Ordr offers an AI-enabled engine that automatically identifies, classifies, regulates, and secures connected devices across healthcare systems. Russell has held senior leadership roles in product management, technical marketing, and engineering in startups and established companies spanning Cisco, Skyport Systems, Global Internet, and Dow Jones. Russell and his team, amongst other things, were responsible for the Cisco Safe Network Security Guidelines. Welcome, Russell. So welcome, everyone. We've got great turnout. More than 120 folks are here and more joining all the time. A note to our town hall audience. We welcome and encourage your participation. Please submit questions to us through Slido. And if you go to the Slido website, and I'll just get some instructions on that. If you go to the Slido website at slido.com and use the event code CPS Health, type your questions in there and we will read them to our panelists. It's important that you're engaged throughout this conversation, so there'll be opportunities throughout the conversation to submit questions, and there'll be time at the end of this conversation for questions as well. And the instructions have also been put in the chat function on the web app screen to your right, so all of you can see that with a link to the website. I will also note that this town hall is being recorded for future enjoyment. I was about to say for quality purposes. I know that that's for quality assurance purposes, but it's for the future enjoyment. So let's get started with the conversation. And you know what I'd like to do over the next little while is talk to you folks about the cyber threats that are facing our healthcare system now in this crisis. And look down the road with you a little bit to the cybersecurity and digital privacy challenges that are facing the healthcare sector as a system as it changes to engage new technologies. And then I want to talk and ask you a little bit about what organizations and individuals can do to protect their healthcare, cybersecurity, and digital privacy in this context. I want to turn first to Michele Mullen from the Canadian Centre for Cybersecurity to talk to us about the risks that she and her organization and challenges that she and her organization are seeing in cybersecurity in healthcare in the country now. Michele.
Thanks very much, Charles. Pleasure to be here. So at the Canadian Centre for Cybersecurity, we actually assess the cyber threat landscape by taking into account information available to us from not only our government and industry partners and academia, but also from both unclassified and classified intelligence sources. So we pull all that together and distill it down in order to get a more holistic view of that threat landscape. And that allows us then to drill in and give you a shot at any point in time on the active threats that we're seeing, in this case against the healthcare sector. So while we agree that the current pandemic has really shone a spotlight on the health sector and the cyber compromises that are happening within the sector, we are actually not necessarily seeing a significant increase in the volume of attacks, but we are seeing a shift in the targeting strategies that are being used. So let me unpack that for you a little bit. Threat actors are actually opportunistic creatures by nature. They will seize upon whatever circumstances help them meet their needs. So although their goals in this case remain the same, they're either looking for a financial profit or notoriety or intellectual property theft, and their capabilities are still just continuing to exploit known vulnerabilities, phishing scams. It's the lures they're using that have pivoted towards COVID-19 or pandemic-related language to take advantage of people's heightened interest in that particular issue in order to elicit the desired responses that they're after. So what exactly is that? So bad actors right now obviously know that the lines between work and home are blurred for people. People are working from home, they're being distracted by children and pets, and they're often working on systems that have fewer protections enabled than they do when they're working from their normal place of work. And so all of those distractions mean that people are even more likely to click before thinking on phishing emails, etc. So what would this mean for you? So normally you would see in your inbox a phishing attempt, let's say disguised as a bank deposit or a tax refund you've been waiting for. Right now, what you're going to be seeing in your inbox is attempts related to fraudulent emergency relief benefits payments or maybe even PPE availability. Because they know people care a lot about those things and are perhaps feeling stressed and impatient about receiving those things, you're more likely to click on it before thinking it through whether it's actually a legitimate outreach or not. So the health sector itself, I'm sure it's no surprise to you, is seen as a soft target for more sophisticated adversaries as well as criminal groups, and one that holds really valuable information, including a wealth of highly sensitive personal information and intellectual property. Partners and experts representing the organizations in the healthcare sector, we have identified a number of both unique and overlapping risks in the following areas of the healthcare sector specifically: patient care and delivery, pharmaceutical research and production, medical devices, equipment, manufacturing and distribution, associations and centers of excellence, and perhaps most importantly, the federal and provincial health ministries and authorities. So in answer to those particular risks, the Cyber Center, as Charles already mentioned, has released some public alerts and some specific advice and guidance pieces to bring attention to and provide specific mitigations for two main categories of cyber threats that we're seeing. One is cybercrime and the other is state-sponsored activity. I'm going to give you a little rundown on each of those now. So cybercrime, especially ransomware, phishing, and business email compromises continues to be used to gain access to personal identity and personal health information. So as with cybercrime, the primary motivation is to hold this information at risk or resell it for profit. Cybercriminals will undoubtedly take advantage of the COVID-19 pandemic to target Canadian health organizations who are under extreme pressure and in their mind are more likely to pay a ransom to regain access to a system or to data. The threat of cybercrime is always present, but the impact at a time when health organizations are fighting a global pandemic can be absolutely catastrophic if not prepared for with a cybersecurity incident response plan. And one of those plans must include ways to do backup and exercise recovery scenarios. We can talk about that more later on in the session. If you're curious about some examples of specific lures that we've seen in recent weeks, we have seen emails with a coronavirus theme in the subject field or as an attachment to the emails. We have seen emails or SMS messages impersonating the government, so whether it be the CERB, the benefits, or other government entities. We've seen emails impersonating leaders or institutions like Health Canada or the World Health Organization. And we've seen emails, links, and web applications that mimic legitimate initiatives and then redirect you to malicious sites. On the other side of the coin is the state-sponsored activity. So at this time, they're clearly going to focus their target on COVID-19 research, technology, and the government response from various countries, as well as policy application. So just like in the rest of the world, we assess that multiple of the state-sponsored cyber threat actors have also very likely reduced their staff and temporarily slowed their operational tempo. But we also assess that their online operations will increase over the coming year as more traditional espionage activities remain hampered by travel restrictions and social distancing requirements. We also see state censorship and influence campaigns continuing to spread falsehoods and to stoke skepticism about official figures and their statements regarding the COVID-19 pandemic. In other words, disinformation isn't just for elections. That said, we don't see that Canada or Canadians are specifically a high priority target for these influence campaigns. Nevertheless, the purposeful dissemination of inaccuracies regarding the origins, spread, or mitigation of COVID-19 can only work to undermine the efforts of Canadian and global public health responses. So what are we doing about this specifically right now? So the Cyber Center, as Charles pointed out, we've been busy adding new advice and guidance products to our website for healthcare organizations and individuals finding themselves living and working in remote environments. The Cyber Center is also taking additional specific action to address some of the cyber threats I've just told you about. We're working with industry partners and other government departments to coordinate takedowns of fraudulent websites that are impersonating government entities. We've actually got some pretty high numbers in terms of how many of those fraudulent sites we've already taken down since the beginning of the COVID crisis. We've also been working with the Canadian Internet Registration Authority, or CIRA, which is a not-for-profit agency that manages the .ca internet domain. And we've helped them launch Canadian Shield, which is a free protected DNS service that prevents you from connecting to malicious websites that might infect your device or steal your information. If we want to look a little bit more deeply into what that is that I'm talking about, the DNS, or Domain Name Service, is a protocol that translates user-friendly web addresses, like in the case of the Cyber Center. When you go to our website, you type in cyber.gc.ca. This service actually translates that into a machine-readable IP address. So it'll take a web address that you type in or click on, figure out what IP address it corresponds to, and redirect your device to connect to that address. This service is intentionally going to stop the DNS operator from connecting you to a malicious site because it's been fed with information that tells it it's a malicious site. So it's a really important stride forward that was just launched this past week, and we hope you all check that one out. We're also doing lots of work with health sector organizations, specifically at both the provincial and federal level, to try to address some of the other security gaps that we know are being exploited by the threat actors that I've told you about. In some cases, this takes the shape of a national effort benefiting all sectors, and in other cases, it's specific work we're doing with hospitals or health associations to address immediate risks and to see where health organizations should best place their efforts. I think I'm going to stop there and turn it back over, and we'll see where the conversation takes us.
Thank you so much, Michele, for that terrific context and that very important information. I want to turn to Jeff actually and just ask a little bit from the hospital side, from what you're seeing right now, what your views are on the threats that you're seeing, during COVID-19 crisis. What are you seeing, Jeff?
Yeah, so I work as a privacy officer, so I'm at sort of the I won't say the opposite end of the spectrum, but I'm dealing with very early sort of people-based detection often of threats. So my office is often I'll call it a first responder almost to good people in our organization who think something's going wrong. And they will often call my office first because I think they trust that we can help them to distinguish between something that's good or something that's not so good for their business day or even their personal day. And so I will, in my week, I experience all of the range of sort of phenomena, if you will, that the previous speaker was just talking about. But really, I want to emphasize from the people end of the spectrum. And I think this is where I spend most of my time, frankly. I'm not in charge of cybersecurity for the hospital. That's somebody else. But I'm a sort of the first best client, as I always say, of good or better cybersecurity around here. And so I'm often seeing for the first time something that's arising in somebody's email inbox, or something that's going on, a series of transactions that might seem odd to just the average person that's trying to get their work done around the hospital. What I see is indeed a reflection of what's been being discussed already, which is that particularly right now, people are working pretty hard, and the amount of electronic messaging has gone through the roof. I mean, I get a lot of messages. We all do on a typical day outside of the COVID context. But now on top of that, you have a brand new set of communications, labeled COVID or look at this, or something that, where you're in a hyper aware state of mind. And it's probably very important that you look at all of these kinds of things. So I can echo the fact that these sort of contexts or moments where people might, on the one hand, have been skeptical about receiving messages about healthcare news or importance in their personal lives, even whether it's at work or personally, have suddenly taken on a different context. So that framing, I think, in people's minds is part of the picture here that we have to deal with. In that context, then I agree that the usual threats or the usual kinds of games that are being played outside of that context are certainly still being played, but they're harder to detect natively because people are in a sort of a more accepting frame of mind, if you will. Right? They're getting messages from folks, even legitimately, that they weren't probably getting messages from before, random teams forming that didn't exist before. They're getting requests for meetings. And of course, these are all, online related, using tools that they've never used before, whether it's WebEx or Zoom or something like that. And so the number of opportunities, if you will, the what we call the attack surface in some respects is much larger than it used to be. It's, if you think of it, it's always a ball, but the question is how big is the ball, right? So the answer is, well, the ball's getting bigger all the time. And so everybody's bouncing around a pretty big attack surface right now. And so the idea, I think, is to make sure that, as usual, for my money, that people are given good information about the way the world really works and the characters and the types of scenarios that literally just don't occur to the average healthcare worker or don't occur to the average administrator, frankly, whose normal job doesn't require them to think like a criminal. So, I mean, this has always been the case. I think now there's a heightened need, as we've always said, to make sure that the most vulnerable link in the chain, which is people, are yeah, reflecting on the situation that we're in right now. Are told that, look, you don't have to react immediately to everything that comes across your desk. I mean, you may have to do so for some things, but it just means you need to be very sure before you act, as is always the case. Now, how you be very sure is contextual. How you be very sure might be technological, or it might even involve, some types of fail-safe routines. And we could talk about some of those. That is, I often say that, people are it's not like they're getting more incapable of dealing with these things. The problem is it's easier to fail. It's easier to do, even the latest thing, and it's still not good enough because, you're only inches away or a click away from complete disaster. And so it's a matter of educating people on the one hand that, these things can happen, and here's what happens next if you're not vigilant. And then B, for the IT side of the house, to make sure, I think, that those folks understand how fragile some of these technology systems are. That is, they're built, pretty well in most cases, but the problem is it's asymmetric. We're not managing for most cases, and increasingly not for most cases anymore. Those are called features. What we're managing for are individual threats or moments. 1 out of 1,000, 1 out of 10,000 times, 1 out of 100,000 times, or 1 out of 100,000 people that are really going to throw us off. Getting people to act that way is very difficult. So often, I think what we're looking at scale, as this ball gets bigger, is technology fixes where machines can help us to act quicker and smarter. At the end of the day, of course, the responsibility always lies with people. And so that's the end of the spectrum that I like to talk about on these panels.
And Jeff, as you're articulating in the COVID-19 crisis, in any crisis where people are stressed, where people are strained, that weakest link obviously breaks down. Mary Jane, talk to us about what you're seeing, what some of your clients may be seeing, or your thoughts on the risks right now.
Sure. And, I've been a health lawyer for over 20 years now. I think I've known Jeff just as long, probably from minute one.
Yes.
So we've had some of these kinds of conversations for many years, including on SARS, including on different risks that come into the health sector. And honestly, this one is a bit unprecedented. When you ultimately send, I don't know what the percentage is, someone can correct me, but when you send half the population home, we know the good work being done in the front lines, that's necessary. And we've also said to many others, go home, set yourselves up, do what you can. So we are now 6 weeks in, and that is almost the first phase, the first wave. I don't want to talk about a curve, but the first wave is past, and we took steps immediately. We were getting a lot of calls, and everyone was scrambling. They wanted to do the right thing, do it quickly, mobilize the people, make sure that programs and services in care, in healthcare, were not going to be impeded in this time. So everybody hustled. That's my legal word. Everybody hustled to make sure we could get people home, get whatever technology in some ways was available, because not everyone who works in a health setting is on Citrix or some other virtual private network. So some may be able to log right in securely, continue to document as they should, and everything's secure. But we sent some people home with more limited connectivity, more limited security being assured. People were on their personal devices. We're going to have a chance to talk about Internet of Things and how that becomes exponential. It's something we worry about always, because very often in any enterprise, you're going to secure the biggest systems. So you'll have the main systems, of which there can be many. Let's say in a hospital, I won't ask how many Sunnybrook has, but many, many, dozens of systems. So we concentrate there, but we also have all of these other ways that personal health information is walking out the door. Well, when you send everyone home, that just is exponential. So depending on whether someone borrowed a teenager's laptop, or they're on their personal phones and they're communicating, they're sharing their information with personal information with clients potentially, just as the setting change. So we're coming through phase one, and some of the first things that were happening was everyone crowdsourcing and getting on association webinars and trying to figure out what are we going to do even with the tech. And we'll talk about virtual care and some of the great things that are happening, but even in order to deliver program services and direct healthcare, to the extent that it's gone online, what do we do about the technology? And many discussions about what's good, what's bad, what's on the front page of the paper, how can we stay off the front page of the paper? And I'll go back for a moment to what Jeff said. It's primarily about the people, and we are saying to them all the time, exercise common sense, take care. We've done some things technically over the last couple of years, probably, to flag for people the possibility of ransomware and the shiny email and everything else. You know, the threat actors have really just upped their game. I did say to this group yesterday that it was fascinating because when you first went online as COVID hit, and everyone had a COVID-19 statement, our law firm did, every business did, every healthcare organization did, we're still providing service, and the hackers did the same thing. They were all over social media saying, no, this is a very important time and we're going to endeavor not to hit the health sector because we're good citizens, et cetera. Apparently it didn't last very long, and the threats are coming. And it's not even just the, the technical threat. The phishing campaigns seem to have redoubled. And I think one of you pointed out quite correctly, it was either Michele or Jeff, even in terms of people's sensibilities, everyone is heightened. Everyone probably for the first while was just consuming COVID information nonstop. It was riveting and probably ultimately exhausting. And some of the phishing campaigns that we've seen just seem to find the right person to whom they might say, hey, listen, COVID is a really hard time, staff morale is down. Could you just go out and grab some gift cards? We'd like to do something really nice. And a new employee who normally, again, would not have had that role, would not have been asked, thought she was being asked by a CEO, went out, used a personal card, and went back 4 or 5 times and kept purchasing. And of course, 20 years in, I'm usually this very positive person. And all of a sudden I was thinking, well, let's just pause it for a moment. It could be fraud. So let's look at that first, and then, okay, let's put that aside. We don't think it's fraudulent, but someone fell for the scam. So we're continually reminding people, and I think we have to. And even though there is a privacy fatigue, and sometimes privacy and security are the last things that people want to see slow them down. Legal probably weighs in pretty closely as well. And I happen to wear both hats. But many, many initiatives are going at high speed right now, using data, of course, and we need access to the data, and we want to do this really great thing, and please don't slow us down. So again, it's how do we carry on that diligence and the rigor and reinforce just plain common sense. To Jeff's point, it really is very often about the people. So ultimately, I think we are going into phase 2. We need to be careful about the workarounds that were put in place at first. If this is going to last a lot longer, and it may be happening in successive times, then we need to make sure that we correct some of the quick things that we did, and rightly so, but correct those and then start to plan for when people go back to work, because there's going to be all of this data sitting in homes all over the globe. And again, if there's something more that we can do from a security perspective, close those holes, because they're simply there to be walked through.
Mary Jane, thank you for that, and I think that's a great sort of link into talking a little bit about healthcare in the future state, and looking at new technologies that are coming into healthcare. You talked about a few of them that we're seeing now emerge through the COVID-19 pandemic, but that I think are going to be with us for a long time. Russell, I want to bring you into this. You are a leader of a company that's obviously at the front edge of technology, security, cybersecurity in healthcare. What are you seeing right now in terms of observations about the current crisis? But more importantly, looking forward, what are you seeing about cybersecurity as a challenge in healthcare as healthcare develops over the next decades?
Great question. And actually, it's interesting. I think of the panel, I'm probably the oddball, where I tend to wake up in the morning and think about how do we protect the things, not so much the people. And it doesn't mean that I'm not a nice people person. But at the end of the day, and if you just think about hospital, it's about care delivery. And a lot of the way that we deliver care is through equipment, right? And increasingly, most of the equipment now is network connected. It shares its information with other systems so that we can aggregate it, we can analyze it better, we can charge for it better. I mean, a whole bunch of reasons why. But because of that interconnectivity, it's a blessing and a curse. And the interconnectivity is why we're having this conversation in the first place. And that, once you're connected, you're open to cyber activity. And, I think traditionally the notion of cyber attacks specifically targeting medical equipment has not been the primary focus for what most cybersecurity has been going after in affecting hospitals. It's been more an incidental contact, where more often they're going after patient data, or they're going after ransomware to get money. But the fact that these equipment that we tend to use is running common operating systems, they're kind of appliances that you don't even know what's under the covers. They're not things that you as an organization can take control of or patch or deal with and kind of become part of your normal operational cycle for what's at risk, what do I do about it, how do I protect it, and kind of rinse and repeat. So it lives adjacent to the normal practice of the hospital, but at the end of the day, it's front and center in terms of the impact that it can have due to cyber disruption, whether it's harming patients or whether it's getting information that you don't want. And so that area, I would say, I think WannaCry was a seminal event, I think, in history and in healthcare about 4 years ago, and it became enforced, where it demonstrated in this area that equipment matters and healthcare organizations can be dramatically affected by ransomware and malware stuff. And I think that was a seminal event for most organizations when the realization, oh my gosh, there's a problem here, and we have medical equipment and a hospital environment that can be impacted by this stuff. What do we do about it? The state of the art at that point was people walking around manually inventorying all of their medical equipment on all of their other IoT systems on a spreadsheet. And, if you just step back and think about what we're looking at right now, you're dealing with organizations, in some cases, the scale of equipment is tens of thousands of systems. That's just not a feasible approach for how you go do this. And it was a great demonstration, I think, to most, the nature and scope of the issue of how we've kind of left that part in our blinder spots. And I think in that area, technology in the last several years now has tried to change the game here and make it more feasible to deal with some of the classic things of what you want to do at scale. Like, can I inventory my systems in a more automated way? Can I understand if they're running vulnerable operating systems? Can I understand if they've got published manufacturer risks so I don't have to have a human go figure it out one by one by one? Can I get insight into which systems may be actually under duress or attack at any point in time or acting oddly? Can I start being more effective at implementing control measures where if I traditionally before couldn't like own and change, an infusion pump and make it more secure because I don't own the software on it, can I at least put guardrails around it so that I can somehow put shielding to make sure at least it's less likely to be impacted? Those types of things have evolved in the last 4 years since that. One seminal event for me personally that I wanted to share with the group that kind of intersects the whole conversation of COVID and then the cyber side is I had the opportunity to go to Singapore earlier this year. And it turns out they too, from a nation perspective, they're about 80% of their healthcare services are public. And they had decided, they're a very forward-leading, technologically progressive country, if you don't know. And they decided that it was time in their evolution to get more serious, systemically top-down about cyber protection, not about just information and not about phishing attacks, but actually about the medical equipment and the other IoT assets, whether it's facilities equipment, physical security equipment, media equipment that's sitting in conference rooms, all of this stuff. They wanted a better answer for inventorying and protection of all of that. And so they kind of went out to bid, and I happened to be there earlier this year representing our company and what we could do with them. But one of the seminal things that hit me kind of personally then is that there was a statement by one of the lead people behind the whole initiative and analyzing different vendors and figure out what they want to do. He kind of said during one of our discussions that, look, you've got to understand our objective. What we want to do is be in place as a nation so that if we run into a situation like a pandemic hits, and by the way, this was like first week of January when he made this statement, and they had just received patient 1 in Singapore who'd been infected by COVID. He said, we want to be in a position where if a pandemic hits and at the same time a WannaCry hits, we still want to be able to operate and deliver care and have confidence that we're not going to impact patients. And I thought that was a very poignant conversation because it takes two of the most significant things that I think of healthcare that intersect here. Pandemic activity changes the entire nature and makes care delivery so much more important. And normal controls and processes go out the window because you got to scale and ramp and do things different, combined with a very virulent activity that actually has significant impact to really affect the core equipment and systems that are critical for healthcare delivery. That was their objective as a nation to address. And I thought that was very forward leaning. And I would offer from a technological perspective, that's where technology is trying to help make that possible increasingly, where honestly, 4 years ago, there wasn't a prayer. And so that's kind of how I look at this from a device and not a people side, but it's really, really important. And it's been a blind spot. Lots of organizations have not focused energies around even the simple inventorying answer. I mean, I tend to talk to a lot of companies and saying, hey, I can provide you insight into all the equipment that you're running, but do you already have a database where you're storing knowledge of all your infusion pumps and patient monitoring systems and cardiovascular stuff and scanners? And usually the answers are spotty. Some yes, some no. Data is not highly accurate. And so there's not even an understanding of what you've got. And if you think from a cybersecurity context, the basic question is, do you even know what you've got? Because if you don't know what you got, there's no way you can understand how you're protecting it. And so I think kind of ground zero becomes fundamental here. So.
Thank you, Russell. And I want to bring in some questions. We're getting lots of questions through Slido, and I want to bring some of these into the conversation. Then want to come back a little bit to the crystal ball sort of project they're doing, look a little bit down the road. And Michele, I want to turn to you as well to ask about your perspective on threats that come as the healthcare system changes. But we've got questions. What can be done to protect medical IoT devices? Russell, this I think this might be in your neck of the woods. You want to field that, or who wants to take that? What can be done to protect medical IoT devices?
Yeah, I'll take a stab at this. Is where I spend my day job. I just offer, I think the reality for most medical equipment, these are things that you get from a manufacturer, and you're generally not able to change what you get, and you generally use it for a long period of time. Imaging equipment, you'll probably, keep around for many, many, many years. Pumps maybe a lot, you'll rotate a bit more frequently, but generally these are appliances, little black boxes that you get, you use, and you patch when you're told to, and that's about it. So most often the common method that you think of protecting workstations, which at the end of the day, a medical device honestly is increasing a workstation, but it can do more because these are just intelligent machines at this point. You don't have the same flexibilities of putting software on them, of understanding what's running on them. You don't even have a bill of materials of understanding all the software that's actually on the darn thing. And so what you need to do is build countermanding protections around it. So the basic things that I would offer are, first, inventory. You need to know everything you got, and you need to know it down to the make, model, manufacturer, and software load level, because that gives you the insight that you need to understand and assess your inventory, and then apply the next tier of the cake, which is the cybersecurity risk assessment. You want to understand what equipment is at risk and what's not, right? And you can blend information that manufacturers publish, which, there's MDS2 forms, which a manufacturer published that tells you kind of what are known vulnerabilities about the systems. There's recall notices from places like the FDA that aggregate knowledge of here's known issues with certain sets of, healthcare equipment. And, you want to understand which one of those apply to your inventory and if there are things you need to deal with. Then you want on the ground intelligence of looking for what's actually going on around your medical equipment and are strange things occurring. The next tier in that risk assessment is then what do you want to do about things when you find a problem? And where medical equipment tends to be different than workstations. With a workstation, if you find a bad apple, you're fine kicking it off the network and say, I don't care. That is not the same decision for medical equipment. These deliver services, right? When I'm giving, when I'm giving patient care with a drip system, I don't kick that device off the network. What I tend to do instead is I want to put guardrails around how I mitigate where that device can talk and who can talk to it. Because a lot of, as has been said earlier, I think Jeff had called out, it's about that surface area of risk in terms of the vulnerabilities and kind of how do I diminish that so it's very narrow. And with medical equipment and other IoT systems, you want to put a shell around where that device can and can't talk that allow the device to function, but doesn't allow the device to do strange things nor anybody else to hurt the system. And you want to be able to implement those types of controls. It's like a personal bodyguard, basically. If you can implement personal bodyguards around your specific medical equipment, then you're in a much, much better place. And so those are the steps, kind of assessment, what have I got? How do I understand risks? And then I had to implement surgical protections around the assets that really matter, that are highly vulnerable. Those three tiers are where we find organizations we talk to are trying to address it in terms of a cake layering approach. And I think that's bang on to what you should be doing.
Jeff, you were nodding during that, and Mary Jane, you were nodding as well. But either of you want to add to what Russell's mentioning?
Well, sure. Just briefly, I mean, in my office, we do lots of privacy impact assessments. We always have. We're well partnered with the security group who does a variety of their own types of assessments, and we try to blend the two. I think for my money, though, I'll echo but extend what Russell was just saying, which is that I think the first line of attack, well, in defending against attacks on devices, is to actually know what the devices do in the first place. So the idea that it's a cyber-enabled device, and I like that Russell emphasized that from the beginning. These are network devices, and everybody said, well, of course they're network devices. That's the point. Well, sure, but what is a feature to someone is a risk to someone else, and
like
so
us.
and so this is the way we always talk, right? Well, who was thinking? What were they thinking? That it's positioned, something's positioned as a feature, and you can talk about video conferencing software. You can talk about any range of devices. That doesn't even have to be just medical devices. And the manufacturer is going to go, oh sure, let's make sure that it can connect to this thing too. And so the first line of defense, as far as I'm concerned, for my money, and certainly in my office, is to simply ask, does anybody know what this thing really does? And of course, the first line answer is yes. It monitors blood pressure. Well, I know that, but it's all the other stuff that's packed in and around it. The cyber enabled, the network enabled, the digitally enabled part that we're concerned about, because that's indeed where a lot of the newer benefits come from. But that's also where the newer vulnerabilities come from. Indeed, vulnerabilities that would not even occur to the average clinician or the users of those devices. So I continue to encourage that when a new prospect for a device or a project, or you call it whatever you want, an initiative comes into my office, we immediately fan out. It's security, it's privacy, it's legal, it's we have an architecture standards review board. If you're going to plug this into the network, then everybody needs to know what happens next. And you might be surprised, maybe you won't be, maybe some of the attendees might be surprised at, the spectrum of diligence that might thereafter be undertaken, because everything comes in and has to be launched next week. And certainly in these days, it has to be launched tomorrow because of COVID. Oh, who knew? We now have to monitor, all of this class of patients that we weren't monitoring before, and we have to monitor them remotely. And so indeed, these are all, digitally enabled remote monitoring IoT types of moments and devices. And the old questions are still the best questions. And Mary Jane's quite right. We were there from the beginning. The first question you ask is, where's the data created? Where's it coming to? Where's it going from? If we're concerned about that. And what you're going to find most times is not just where the data is coming and going to, which is probably, for the most part, all good ideas. It needs to go from here to there and things like that. But the question is how vulnerable is it along the way? Because there's many, many stops. And typically you're involved with not only the clinical services group, but you're going to have one or two device or data managers, third parties in the background. These days, always in the cloud or on somebody else's computer system is basically what we're talking about. And so the degrees of freedom in terms of the complexity of the problem has grown exponentially compared to just an on-prem, only on our network type of device, if you will, even if it was open to the internet somehow. This is a much more complicated problem than we had before. And indeed, right now is not a great time to advocate that we slow down and do more homework. This is this is a people problem because people are, they're in a hurry. They're probably getting free equipment in many of these cases too. Who doesn't like free? And free lets you move faster because you don't have to find the money. And so this is just a formula for adding up to, we really, not only are we doing more, but we're probably doing it without really knowing the consequences, right?
Mary Jane, you were nodding your head throughout that. Talk a little bit about your thoughts on this.
Yeah, I just have to echo both on this front. And I want to peel it back even one layer further because Jeff's right. We get asked in terms of privacy and privacy impact assessment, where I also think we could pull it into the sight line is even on the procurement process. So not later once we have this great medical device, but as we're going out to get it. And the procurement processes are pretty exacting. What I predict we'll see is similar to what the Privacy Commissioner has said about audit functionality. There were some bad cases some time ago where we realized we don't even really know half the time, maybe half is not very generous. Sometimes we don't even know where people go when they come into an electronic medical record, for example. So there was a big push to make sure that we know who's in, who are they, how long are they there, what did they do while they're there. Putting it back onto the expectation of the commissioner, for example, looking at procurement processes. If you go out to get a new EMR, are you going to make sure that you've got audit functionality? I would say the same thing about this. If we are going to be bringing in all of these devices, many of which are going to be, there's a competitive component, we should be baking into the process. Tell us now, have that as part of that expert panel or whatever the group is called that does the vetting and has the clinical expertise around, maybe it's blood pressure, maybe it's a cardiac piece of equipment, whatever it is, to understand what is the privacy and security, what can they demonstrate if they are a proponent in a request for proposal as we're starting to take it on. Like, tell us, because that's going to be not just a competitive advantage. I mean, it's a fundamental component. So I would say take it all the way back there, and then also be considering, as Jeff and Russell both said, like tell us what you have, and understand what also happens. Less a cyber issue, but if the cyber issue hits and that equipment goes down, we talk all the time about business interruption and did we have the right patch and did we have the backup such that we can be up and running again by midnight. Well, if we don't know that about those devices and the whole system goes down, what exactly is our process to ensure that we have manual processes clinically so that care can keep being delivered? And I go back again to Brad Smith, the president of Microsoft, making comments to the UN, talking about a particular health situation where there was a bad cyber hit, and ultimately said, the wisdom, the business continuity plan consisted of saying, hey, young person in healthcare, go find someone older than you who can tell you how to do it manually. So again, it's not enough. I think that if we have all of these medical devices that are collecting vast amounts of data, if they go down, and we spend all this time talking about all of the new opportunities in artificial intelligence, and it's really exciting. And I'm always, I sound like the wet blanket, but I want to make sure that as we automate everything, we rely on the new technology, and it's shiny and wonderful for care. But if it doesn't work because there's a cyber attack, how do we make sure that we can continue to deliver the care? So that's going way back to procurement, and then it's looking, I don't mean looking forward to in a positive way, looking ahead to the, not the if, but the when of when that system goes down.
Michele, I want to bring you into this and get your thoughts from the position of the Cyber Center on the healthcare sector as we look forward, and your considerations about working with the sector as a whole in terms of managing the cybersecurity challenge, and then some of your thoughts on what we've just been talking about these new technologies.
Sure, happy to. So we've, in terms of just what's happening in terms of looking forward, so we've certainly learned from our partners in the health sector that virtual healthcare, whether it's telemedicine or electronic medical records or remote patient monitoring, none of this is actually new, but it is being adopted with a hastened pace or a more rapid pace. And so I think one of the most important things is to make sure that the balance of the risk calculus is done. So while we know how much is to be gained, so for example, providing care to remote communities in Canada's north or other situations, there's a lot to be gained from rolling out these tools and making them available more quickly. But it's really important to balance the understanding of the vulnerabilities and the security flaws that come with introducing those types of tools, especially when they're being used or offered over technologies that weren't necessarily built for that purpose. So for example, if you've got doctors' offices trying to provide telemedicine using, for example, that wasn't developed for the purposes of telemedicine, those service offerers might not realize that they're actually introducing additional risks and additional vulnerabilities that if they were choosing a purpose-built tool wouldn't be introduced, because those things are built with security in mind, because it's meant for providing health information between two parties more securely. I think beyond that, it's really important to know that the responsibility, so especially when we're talking about IoT devices, it's a shared responsibility between, in this case, whether it be a hospital or health organization, and the actual person that's wearing it or using it, the actual patient or the user end of the bargain. So I'll talk about that a little bit. The bottom line here is the math is simple, right? The more devices or endpoints that we've got connected to hospital networks, the more vulnerabilities that are being introduced. And I think we've already heard from whether it be Jeff or Russell that it's really about making sure that the appropriate security controls are in place at the hospital or the service provider end. And sure, it's about making sure that you put proper markers down in procurement, requests for proposal and so on, and making sure that the right questions are asked at the upfront point. But once you've actually got the devices and they're going into service, this is where that balance comes into play. And this is what's tricky in this part of the cyber universe, is that it's not a one-size-fits-all kind of thing. Life was easy for the Cyber Center when we were working only with federal government departments that had very similar, I'll say, maturity levels in terms of the cybersecurity posture. They had dedicated IT staffs and decent funding. And even then, it was a struggle to get the appropriate security controls in place. In the healthcare sector, we're talking about a wide range of maturity levels in terms of how much cyber acumen is actually present in the workplace, as well as budgets, wildly differing. Different entities are putting different emphasis on this, and not every entity is sized the same. Not every entity has the same budget to put into these protections. So I will draw your attention to, there's two different sort of, I'll say, sets of security controls that the Cyber Center has made available via our website. One is something we refer to as our top 10 IT security actions to protect internet connected networks. That's really focused on larger entities like federal, provincial governments that actually have full-time staff that can actually implement these things and have budgets and have ways of making these things happen that are at a more, I'll say, sophisticated level. At the other end of the spectrum, though, we actually have a set of baseline, what we call baseline security controls for small and medium enterprises. And those are far more practical, affordable things that the average business owner or the average, in this case, healthcare sector business can actually do to implement for themselves. And so it really is about sort of sizing things right. And back when I said that this is a shared responsibility, we have to remember that the people who are actually going to be using these devices also have responsibility to do things more securely. We have to remember a lot of these devices are being enabled via mobile devices that the patients or the wearers are going to have. So it's making sure that they are behaving appropriately with how they're securing their mobile devices, but also being aware of the fact that if you are uploading data from one of these internet-enabled devices, if they're doing so over public Wi-Fi or using Bluetooth, then they should also be making sure that they are aware of the things and the ways that they're doing that to be as secure as possible if they want their own health data to be protected. So I think it's a two-way street here, and I think folks often forget that in this process.
Thank you very much, Michele. And I want to bring in a few questions. We're getting a lot of questions that are being asked, but I just want to bring in a couple, and then I want to go, we've been talking about it already, but go a little bit to the solution side, and we have been chatting about this, but talk about specific pieces that you would recommend for organizations and for individuals as well, and we'll go around the group asking for that. A question here on how in Canada is data typically protected, that is medical information databases protected or authenticated in the healthcare sector. And this goes to another question that's here around standards. And so maybe, I don't know if there's anybody who can tell us, is there a standard or standard setting organization in healthcare in respect of cybersecurity in Canada or in the provinces that's working on these pieces right now? Jeff, I don't know if that's or Mary Jane or Michele, if that's a point you might know.
Yeah, I can't speak to specific organizations necessarily in Canada. I mean, traditionally, what you're looking for are data center, management standards. So SOC2, what's called SOC 2 standards, which is a US-based auditing standard, typically undertaken by very large or medium to large size organizations because it's expensive, it's time consuming to do once, and if you're doing it right, you're doing it every once in a while too. And I can say that on the one hand, some of the major healthcare providers in Canada, hospitals and others, are seeking these standards now from vendors who not only come with technology solutions for at point of care, but who are in fact, of course, managing data on the back end. This is good because to the conversation we've been having, it enables better surveillance of healthcare status and stuff in real time at scale. But looking for those kinds of certifiable standards, and there's many, there are others. Cybersecurity or security professionals are familiar with those right now, whether it's ISO types of standards or others. It's one thing to ask for them. It's another thing to know what they mean or to be able to evaluate them. Again, in a time-constrained, resource-constrained environment like healthcare. As I've said for years, the banks have done a pretty good job for many years procuring and evaluating technology based on those standards. Healthcare should, try to do the same similar, but you're as good as the folks that are on your team and are trying to, work those standards, if you will, for every vendor that comes in. So I think that those standards already exist. Many of them are international or international-like types of standards. I'm working on an international standard right now to enable privacy by design, for example. Look, at root, it ends up being it's being considered as possibly a certifiable standard based in, of course, good security control technologies that just happen, to pay off for privacy. So I think everybody needs to pay attention to what those are. But even if you know what they all are, if you can name them when you see them, the question is, what does it mean to management? How does the security team, say to management, well, look, you need X, Y, or Z, otherwise you're in trouble. Management's always going to come back and say, well, that's interesting, but we're already in trouble, in other dimensions, right? And so are you telling me it's a definite no, or is there any room to negotiate here? And this is where the art of this kind of comes in at the end of the day. So they shouldn't be taken as a panacea. They're necessary, but not sufficient to make a decision. Right?
There's a good question, a great question here, and I'm glad we can't have a healthcare conversation in Canada without talking about budgets and without talking about money. It's like a national rule that we have for good reason, because it's so important. Are funding pressures making cybersecurity and healthcare worse in Canada? Mary Jane, you're sort of nodding your head, or you're muted, Mary Jane.
You are right. Thank you.
No.
I probably have that quizzical look because, in fact, in the public health sector, we are always budget conscious. Everything works across the continuum up to the end of March, the end of the fiscal year. People are sorting themselves month by month to see what can we do. We've had privacy breaches and security breach cases where we've even gone to regulators to say, here is everything that we have done to close the gap. We've mitigated, we've trained, we've done many things. There may be some technical things that we need to purchase. And to be very fair, it's not going to happen in this budget year. It would have to be phased. And obviously it's up to any commissioner to say that's good or that's good enough, or isn't that great? But ultimately that is something that's a constraint that we absolutely have to deal with. And certainly, even from a legal point of view, we're not like the US with large damages awards in terms of clinical outcomes or privacy and security. But we've had privacy breaches over the past number of years that have suddenly emerged as class action lawsuits, something that we didn't have before. And the healthcare sector is acutely aware. It has people's full attention. People are sitting up very straight, boards are taking it extremely seriously, and yet we're within fixed budgets. We know even from the courts in terms of the types of monetary awards that can be made. There's some case law that came out of the Ontario Court of Appeal that set up a cap of about up to $20,000. And of course, in an electronic system, which I can certainly say, having worked on PHIPAA, the health privacy legislation years ago, we weren't really doing the math back then. That cap didn't exist, and they were primarily paper records. And breaches can happen. The whole topic today is a cyber breach can come in and have a broad and devastating impact. And if we start to talk about budgets to not only procure and put in place and monitor and respond, but then actually pay out any kinds of damages, those class action lawsuits have not really been borne out as yet, but we're really aware suddenly that it can be very costly. I have lots of questions about the insurance coverage for cyber liability as well, and how would the insurers ever pay if the cap on clinical damages, I think probably $15 million is one of the most expensive awards in Canada to date for a bad clinical outcome. You do the math of 20,000 times tens of thousands of affected people, and the various breaches that we've seen, again, on the front page of the paper, the math is enormous. So we need to sit back and assess that risk as well. But money is definitely a factor.
Good question great question from one of our attendees about legacy systems and the cybersecurity risks that are raised by legacy systems becoming digitized or legacy systems existing. Lots of nodding heads here. Russell, is that something that, I mean, you presumably see in your clients at Ordr and in other contexts?
Oh, I mean, I think the legacy system, the debt that's owed because of the use of legacy systems, which are, I mean, we were just talking about finances. Why do you have legacy systems? Because it takes a long time to kind of just switch systems over. The more intertwined those systems are with your day-to-day operations and services, the more complicated they are to rejigger. And so there's good reasons why you use them and want to maximize the benefit. The reality is, I will share with you, our organization is involved with providing technology that allows people to understand, legacy assets that they've had for a while. I'm trying to remember if we've yet gone into healthcare institutions that do not have embedded Windows ME software running on healthcare equipment. Let me restate that. Windows ME. Then we can talk about Windows XP. We can talk about Windows 7, which is even more recent. And I mean, it crystallizes the entire conversation.
You know why? That's because some video games only play on Windows.
That's awesome. No, but I mean, and I'm talking about endpoint device, but same is true with server applications, a bunch of stuff. But I think legacy systems have always proven, you want to keep using it as long as you can. And I think, there's a conversation about supply chain that Mary kind of brought in a little bit, which I think is important consideration here, because part of what often goes into the considerations for, procurement through the supply chain, does cybersecurity enter the conversation of how retirement planning should occur for equipment? And I think the legacy conversation ties into this because in my experience, most often procurement decisions for when you pipeline to get the next generation of something is usually more of an operation, a financial and capability perspective. Very rarely does the cyber conversation enter into that discussion unless it's a fire drill. And I think that to be true to this audience and to this topic, cyber as part of that dialogue is important because that allows you to say, I'm sorry, you are actually running on something that Microsoft doesn't support anymore. And, we should care about that because there's good reasons why that equipment may have more risk to us. And often the legacy equipment, to be honest, too, tends to be more critical or used. Either that or it's so isolated and so far you can't find it anymore. And maybe there's kind of both ends of the spectrum. But both those are true, and that it is a real consideration.
Some more questions here. One excellent question about the extent to which clinicians are engaged in these considerations. Is this a technologist, like a technologist issue, or is this also a clinical medical issue, and to what extent are clinicians engaged? Jeff, I don't know if you want to speak to that, or Mary Jane or Russell.
Yeah, well, I think they are engaged. I mean, certainly around here or around some of our peers, I know for a fact it's impossible to imagine that a significant clinical management system would be onboarded without direct involvement of senior leaders on the clinical side. And let's admit, if for no other reason, then they're the champions of some of these systems. The need for the system is identified often by the senior clinicians, certainly for clinical management systems, obviously. And so then the art of it, I think, is to say to them, well, you can't quite leave the meeting yet. Thanks for the PowerPoint presentation, but we have our own presentation then on, if we were to do this, here's what a day in the life of a user would look like or something. It's not quite as free for all as you might imagine, because people are on mobile or however they're accessing the things. There is something you're going to have to deal with called VPN, or there is you're going to have to deal with two-factor authentication. And very quickly, and certainly at a senior level, it's very important that those senior clinical leaders understand what a work day is going to look like. I mean, look, don't forget, even on the features and functions side, there was a story last year, I believe it was in the Atlantic, if not the New Yorker, I believe, on a major clinical management system in the U.S. company, very successful. And the doctor basically said, I'm burned out because I can't even just to get around the block on ordering things or something. It's death by 1,000 clicks. Well, you're going to get, and you might have imagined in that case that, well, somebody would have told them early, well, you can buy this system, but it's going to be a death by 1,000 clicks if we're not careful. Equally, on the cyber side, if you're really protecting the system well, here come the passwords, here come the second factor things and things like that. You're going to have to use, sorry, you can't use your own phone. You're going to have to use our phone. Or if you use your phone, it's not going to look or act like your phone anymore. Or maybe it will, but that's going to be expensive. And so I think that clinical leaders are engaged, but it's really a matter of making sure that they have as much responsibility for the tough decisions that the non-clinical leaders have to make around trade-offs between features and functions and cost and risk and things like that too. Everybody's got a stake in that. It's no good for clinical champions to say, well, this is what I want, work all that out, and I'll be back when we're ready to sign the deal. I think everybody's going to have to, has a stake in the risk management part of it. Right?
I was going to echo that, if you don't mind, Jeff. I think one of the things that we've tended to run into, if you ask the question like, who's responsible for the protection of, the cart on wheels or a medical asset, there's not a clear answer. It's, the health tech who's procuring the device, who, operates the device and does care a bit about making sure the device functions right. Is it the security team? Is it the IT team? There's a combination there of kind of three legs of a stool that somehow all need to combine together and kind of, help prioritize and operate kind of this stuff, because everybody's got a bit of a stake. And we tend to see that those groups don't always have the same gravity well of how they want to work together and cleanly how they work together and what they think is important.
Right. And I won't go on, but we've talked for years, Mary Jane knows as well, I'm a champion of, good and better IT governance. That's a whole topic in and of itself. It's directly linked to the cyber assurance discussion. And, there are, as we've talked about, there's standards for that. There are methodologies, there are internal controls for that. And so the challenge these days is for the CIO or the CISO or whoever it is to make sure that all of those dimensions of this problem are well articulated to folks that are spending the money, the senior leadership team, and then they understand, look, that yes, there are trade-offs, but some are more interesting than others. The all beer, no peanuts solution is not going to work, folks. You need some peanuts with some beer. If we go ahead here, it can't just all be fun and games, right?
I'm going to work that into my next round of privacy training. I do want to say
that's an old economics joke, beer and peanuts.
Well, and to be fair, I remember going in one time and being told as I came into one of the teaching hospitals, you're going to get 5 minutes on the agenda. And I say, listen, I can do privacy in 5 minutes, or I can give you 3 days or anything in between. Fine, I have X minutes. Here we go. And what I can say is that the 17 or 18 chiefs of medicine kept me there for over an hour. It's almost as though they had stored up all of the privacy and security things that they'd been reading and hearing about and wondering about with some of these devices. And, a really thoughtful, good discussion. And at the same time, and it's not that others who are not the chiefs are cutting the corners. What I will say is they're also being approached by industry and coming kind of late in time, probably, and I suspect they knock on Jeff's door. They come late in time and say, hey, we have this great idea. It's going to transform clinical care. We're going to have an app. We're going to use the data, or we've already signed something, and off we go. And often Jeff and I in our roles are kind of pulling it back to just say, well, let's just slow it down a little. We're all about the clinical care. We don't want to impede you. But I suspect a lot of places are starting to, and Michele made the point, some of the tools and thresholds, even for the smallest organizations, just to start to think about how do we do that practically. everyone wants the data. There's a lot of data ambition. And I say this all the time. So I think whatever we can do to crowdsource the solutions and to have this kind of organization at the ready with some helpful tools. You want a mobile app? Well, as Jeff said, there are a few hoops that we need to have you jump through, bring us that information. Most often people are saying, health researchers are saying the same thing. They'll say, just tell me what you need me to do or to say. And I said, well, you may say it, but I need you to mean it and actually do it. You need to live it. But I think there's a way to, again, systematize it a little bit so that we're not starting over off the side of a desk every time some great new app or, Russell, a device comes to bear. Otherwise, we just look like the group that's impeding science, impeding care, which is not really where we want to be.
Thank you, Mary.
If I can weigh in.
Oh, please, Michele, please.
Yeah, I was just going to throw my hat in the ring there just a little bit, listening to everything. So we get asked a lot for help from the folks in the healthcare sector that are responsible for IT security, and they're usually not, I know that doesn't surprise you, they're usually not a C-suite level of executive, right? And so they're looking to us quite often to give them the wow factor or the scare tactics that'll work to get the C-suite's attention to actually invest in the security aspects of these things, as opposed to chasing the newest, shiniest object that's being offered by some really great marketing skilled folks. And we remind them that the healthcare sector is the second highest industry suffering from breaches and cyber attacks, but that they cost the most. So we've got stats here that for the 8 years running, healthcare organizations have had the highest costs associated with data breaches, costing on average $408 per lost or stolen record, which is nearly 3 times more than the average industry cost per record of about $148. And then if you look at what some of the privacy breaches that have happened, if you Life Labs, for example, that medical testing data breach that happened in 2018, that ended up affecting 15 million Canadians. So the math adds up really quickly. And so sometimes it really is a matter of making sure that the folks who have the hands on the purse strings are intimately aware of what the cost avoidance figures are by taking the time to do the security thinking or choosing the, as you say, app or the device that has a better security story to tell, because of the downstream cost avoidance that can be achieved by doing that.
Thank you very much. Thank you, Michele. And I wanted to come back to you, actually, Michele, for our sort of closing remarks. We've had a terrific conversation and really just scratched the surface, I think, of a lot of complex topics in healthcare, cybersecurity, the current crisis, looking forward. But I'd like to take in just the 6 minutes that we have from each of you, just a couple, one or two takeaways that organizations or individuals could take with them out of this conversation to implement either right now in the context of COVID-19 or looking down the road from a healthcare perspective to improve the cybersecurity in their healthcare organization or in respect of their personal healthcare information. So Michele, just starting with you, and you've already talked about a lot of them, and the Canadian Centre for Cybersecurity is doing a lot of this work, but interested in your thoughts on that as we go around.
Sure. So I mentioned a couple of pieces of guidance that we have available on our website, one to do with securing mobile devices, one to do with securing things, Bluetooth devices. I think a lot of IoT devices are also cloud enabled. So looking at some of our simpler guidance in terms of how to protect data that you've got stored in the cloud. But I would say the two questions that I would want to see citizens ask before making a decision about accepting the involvement of one of these devices in their lives would be, number one, being inquisitive to find out exactly how their health data is going to be stored and handled by not only the healthcare providers, but the companies that are involved with the devices that are in question. And then the second one is to do some research yourself, whether you're the person that wants to offer this equipment or whether you're the citizen that's being offered it by your clinician, on whether those particular devices are actually updatable, security updatable, right? Are there actual notifications and processes available to update your device once it's in your possession? Because once you've installed, whether it be one of these glucose monitors that goes under the skin or a pacemaker or any of these other devices, once it's in your possession as a citizen, the data that it puts out, it's up to you to make sure that's protected. You can't expect necessarily that to be the number one thought process of the clinicians that have suggested the use of this equipment. So I think it's really important for folks to realize that, especially because a lot of these IoT devices are not patchable. And if you do patch them, it'll avoid the certification or the warranty on them. So it's a whole different realm of technology that we're trying to protect. And I think it's really important for people to realize that.
Thank you so much, Michele. Jeff.
Sure. Well, again, as I started, I guess I'm a privacy officer, so I always encourage people to follow the data, whether and understand what certainly either personal information, if not personal health information, is in play. That's important from either a personal perspective. Everyone who puts on a smartwatch or a Fitbit or something like that should, and I echo Michele, take a few minutes, if not a couple of hours or something, to figure out or to understand exactly what data transactions are coming into and going out of the phone. There's many great books on the market these days that would warn you that there's probably more going on than meets the eye. I won't quote those books today, but they're very important for the average consumer to read. You can't read them, get somebody to read it to you and explain it to you. I think on the security side, and when we're talking enterprise or corporate, I think it's, as always, it's important that everybody has sort of not only a chance to hear what the security risks are in implementing a device, but has a chance to sort of reflect on what their risk tolerance or appetite is in approving such devices. And as we've talked about, different folks will perceive things differently just because of their personalities, or because of their professions, or because of their embedded sort of responsibilities or biases that come from those. And at the end of the day, it's about some formality, about someone saying, look, so I've been explained these risks, but I'm still, willing to go ahead. What that really simply means is, I'm buying a Ferrari. I understand that if I'm going 200 miles an hour and I hit the brakes, two things have to be true. The brakes better work. And even if they work, it may not work out just the way we thought. So the faster you go, the more you need to be able to stop and stop well. So it's really about the coherence and integrity of that management risk discussion, sort of rooted in, unfortunately, bad actor stories. How bad could this be? That is, I think, the name of the game these days.
Thank you, Jeff. Mary Jane, to you, and then to Russell for closing words.
Yeah, and I do like Jeff's comment about risk appetite. Ultimately, we want to know that a decision was made and it was thoughtful, based on good information. Maybe it had to be made quickly because the alternative isn't really, you don't make a decision. I mean, it is healthcare. We have to continue to deliver the healthcare, but to the extent that we can slow it down even for a second, to have that pause, to at least allow that information to be known. I would say the same thing with consumers. And sometimes the easy way out is someone will just post on social media. No, people don't care. They don't care about their privacy or data. They just want that thing. They're going to scroll down quickly and click off, I agree. And that's the trade-off they make. I'm not really sure that's true. People they want access to their information. They absolutely want to know that you are protecting it if you're going to hold it in trust for them. And to the extent that they are connecting themselves, I think we just need good resources, to Michele's point, help educate, do the drop down, and those that want to have a bit more information and choice will start to make those choices. I'd also just say, I think that virtual care has, it's not new, but this has been a remarkable opportunity to test it in fast. So I think we will see some things change about the way people work at home and how virtual care is delivered with a little rigor behind it. That's all good. And then just get rid of the workarounds.
Thank you, Mary Jane. Russell.
You're on both fronts, both personal and kind of a work side. I mean, the basics you were talking about before, I want to, being prioritizing to have an understanding for what you got, what it's made of, to the point before, where did it come from? Do I know anything about the org? What it's doing, and is it doing anything odd? And do I have the self ability to put protections if it is doing something odd? On the corporate side, all of this applies from a healthcare organization of, inventory, understanding what you got, down to, is it doing something? What is it doing? Is it doing anything weird? And do I have an ability to see that in the first place? And then if I so choose, and we agree as an organization, we want to put protection measures in, can we do so? And those are kind of foundational ones. On the personal side, I think all those things apply. I think most consumers don't have an appetite to try to audit what all of your systems are doing, other than to find out if your kids are going to strange websites that you don't want them to go to. And I think that same question should apply, especially when we start thinking about more medical service delivery in home. I'll do the Alexa example. I have a great friend who's a chief security officer, and his wife wanted to get Alexa at home. And I appreciate everybody who likes Alexas. Just, you've got a microphone in your home. And what he demonstrated his wife is he could hack his box and, listen to everything she was saying. And so, the demonstration of that is the consumer equivalency of how much do we personally care if these things actually do something odd, and do you have an ability to understand if this thing is doing something odd? Can you see that? Do you have insight into what is actually going on? I think demanding of the systems that we tend to use and buy, if you have an ability to audit them, that would kind of be for me as a citizen that I would care about. Unless we've opted out as individuals to say, at the end of the day, privacy is gone at home, and it is what it is. But I don't think everybody's there yet. Some have voted that way, some have voted on the other way, and most of us are in the middle. We just want to keep all the work out somehow.
I think that's an illusion, yeah.
Exactly. So
thank you, Russell, and thanks to this wonderful panel. We've come to the end of our time. It's been an absolutely fantastic discussion. As I said, scratch the surface of this incredibly important topic. I want to say a particular thank you to Michele Mullen from the Canadian Centre for Cybersecurity. The Canadian Centre for Cybersecurity is doing incredibly important work in protecting and educating this country in respect of cybersecurity. And we're very grateful, Michele, for the time that you gave us today and for all the work that you are doing. I encourage people to go to their website for the best and most up-to-date information on this and other topics. Jeff, Mary Jane, Russell, thank you so much for your contributions to this terrific discussion. So much appreciated. And thanks to everyone who joined us for this, the third of our town halls. Our fourth town hall is this coming Tuesday. It is on cybersecurity in home education technology during COVID-19. Homeschooled security and privacy of education technology during COVID-19. Please join us for that at 4 o'clock. You'll be getting invitations and you'll see them on our various websites. My colleagues will also put up in the chat box the links to the Cybersecure Policy Exchange, as well as Policy First Response, which I mentioned at the beginning of the session. Thanks again to everybody for joining us. Thanks to our wonderful panel for being here. And special thank you to Michele for joining us. And everybody stay safe and have a good evening. Thank you.